Hello and welcome. I'm Jeff Terry. I lead the clinical operations practice at GE. We're working to improve safety and capacity management in healthcare. That work includes the GE Patient Safety Organization, the sponsor of today's discussion. Today's webcast is the third in an ongoing series exploring patient safety and quality with leaders in the field. Our first webcast focused on the importance and difficulty of improving safety culture. Our second webcast discussed the role of hospital leaders in improving safety. If you missed them, those webinars are available at nextlevel.gehealthcare.com. Today's discussion will focus on the role of governments in improving patient safety. After the discussion, the panelists and I will take questions over the telephone. You can enter a question by clicking on the Q&A panel in the lower left quadrant of your screen. For today's discussion, I'm excited to welcome a pair of leaders that need little introduction, John Halamka and Peter Ancud. Dr. John Halamka is the CIO of Harvard Medical School and Beth Israel Deaconess Medical Center, chairman of the New England Health Electronic Data Interchange Network, and professor of emergency medicine at Harvard Medical School. Many of you may also know him from his books or his popular blog, Life as a Healthcare CIO. Thanks for joining us, John.
Happy to be here. Thanks.
Dr. Peter Ancud is the medical director of the GE Patient Safety Organization. Prior to joining the PSO, Peter was the Senior Advisor for Patient Safety at the National Quality Forum. Prior to that, he was the Chief Patient Safety Officer and Vice President of the Joint Commission, where he initiated the leadership strategy for the newly established Joint Commission International Center for Patient Safety, and also oversaw annual development of the Commission's National Patient Safety Goals. He is an at-large member of the National Board of Medical Examiners and serves on the board of the National Patient Safety Foundation. Thanks for being here, Peter.
Thanks, Jeff. My privilege.
Gentlemen, the federal and state governments obviously play an enormous role in healthcare funding, regulation, and research. For today's discussion, we want to focus on how government action is helping or could help to improve patient safety. With that in mind, what comes to your mind, John, is the best example or a great example of government action, either at the state or federal level, helping to improve patient safety?
Well, I think we all regard an electronic health record as important for measuring quality and improving safety. Problem is, the average primary care doc doesn't exactly have $40,000 or $50,000 sitting in their bank account, and they're a little reluctant to change. So the federal government, through the whole stimulus and meaningful use program, has come up with a set of criteria. What is it you need to implement? And not just paying for hardware and software, but paying you for demonstrating your use and the actual policy outcome of achieving quality and safety improvements. So I actually think this construct called meaningful use and the stimulus dollars as a catalyst have been very successful.
Terrific. And I know we'll come back to that over the discussion. Peter, I want to turn to you. One of the things that our audience really enjoys is very specific nuggets that they can take back to their operation. You've participated in a variety of organizations. What comes to mind for you as a specific program or two that you would highlight that folks can draw on for resources or insights about safety?
Sure. I think the good news in all of this, we're now what I call sort of the 10 years into our common era of patient safety, and there have been a variety of initiatives that have come into place. Many of them have come as a result of the government's own initiatives at the federal level. Several now are just beginning to come online within the state initiatives of different types. But the Agency for Healthcare Research and Quality, or AHRQ as we often call it, is a federal agency that has tremendous resources out there, both for the medical community, the clinicians, the organizations that are involved with healthcare, as well as for the general public and everyone else who wants to learn more about safety as well as quality within healthcare. They have a variety of resources on the web. They have a variety of publications that are available. And so I'd encourage individuals to pursue those. In addition to the federal level, though, I think it's well recognized that the Joint Commission has, in its role as the primary accreditation agency within the country, has also developed up a variety of resources that are available to see better what's going on as we move into this era of transparency and able to find what's actually specifically happening in organizations. Their program Quality Check is somewhat of a competitor to Hospital Compare, which is what AHRQ utilizes. But they're complementary and both very robust in terms of finding more information. And I'll mention one other organization which I think is under-recognized but has a lot of resources both for clinicians and providers as well as for the patients, and that is the National Patient Safety Foundation. Tremendous number of resources. Obviously, though, there are other professional societies, professional organizations, and a variety of entities within federal and state governments that have resources as well, but those are some good ones.
So we have Meaningful Use, ARC.gov, Quality Check, NPSF, all great resources or programs helping to improve safety. For a moment, John, what about the other side of the coin? Are there, obviously all action from whether it's government or different organizations is well-intentioned, but are there examples of rules or activity that comes to mind that have actually hindered work to improve patient safety?
I think the danger in implementing a new technology is it does reduce errors, but it causes others. So examples. Probably you would not, as a doctor, write for a medication called Ativan if somebody had high blood pressure. But Ativan and atenolol, they're in alphabetical order right next to each other, and if an EHR is designed poorly, you might get an error of commission, a person writing for the wrong medication simply because the software is causing an error that would have never occurred manually. And I think we all agree e-prescribing is actually one of the wonderful ways we can improve patient safety because it goes from doctor's brain to patient's vein with no handwriting in between. But it is upon all of us in IT to design systems so we don't create new errors. That can be a problem.
I think that's an important point. I keep coming up to the number of, if by the time it's in the brain, it goes through and gets to the patient's vein, to use your terms, there's about 100 steps involved. And those individual steps are all points for potential failures. And so the technology piece can help, but we have to have the buffering systems all the way along so that we can implement these with as much safety as possible and not become overly dependent on the technology. We tend to dumb down when we're using technology, and so we tend to oversee these opportunities for error.
Are there examples either of you seen where that's someone or an organization has managed that challenge particularly well?
Well, the Joint Commission, interestingly enough, some years ago said medication reconciliation is very important. At each transition of care, we want to make sure that the patient has a well-understood medication list. Do you know it's really hard to do electronic medication reconciliation? We at Beth Israel Deaconess had to rewrite our software 5 separate times in order to make it usable enough so that clinicians would say, this actually saves time and improves safety. So it was this iterative, do it, learn from it, iteratively improve it, and now we have a very functional automated medication reconciliation that was a Joint Commission catalyst to drive us to do it.
And that's an example of sort of the top-down drivers. You pick choices of topics that are important, they're relevant, and need to be changed. But it's also an example of how it wasn't necessarily fully thought through how to implement. And so for the last 6 years, organizations have been struggling and continue to struggle. When I was at the Joint Commission, I used to laugh. It wouldn't matter what venue I was in, what I was talking about, somebody would want to talk about medication reconciliation because it's such a burning hot point for them all the time. And we still haven't got it solved.
That's true. Yes, and what speaks to me about that as well is the importance of being a learning system and a learning organization and constantly capturing the lessons and putting them back into practice. If we think about innovation, and one of the programs that was recently announced, I guess 3 weeks ago now, was the Partnership for Patients. So CMS announced a $1 billion program with the aim of reducing preventable injuries by 40%, cutting readmissions by 20%. Of course, that comes on the heels of Meaningful Use, which you mentioned, and Shared Savings, 2 other government incentive programs. Peter, I'll ask you, in your opinion, I guess what's the strength of programs like the Partnership for Patients, and what kind of activity do they really drive?
I think the biggest important factor in these is it gives sort of a top-down approach, as I mentioned a little bit earlier, and it creates awareness. It doesn't necessarily create the solutions to the problems, but it creates awareness. And if constructed well, these programs can provide opportunity for facilities, organizations, even individuals to provide the upflow, if you will, of their information, how they've solved those problems so others can learn. Without these national focus programs, we tend to just stay localized. All politics are local, as we know. All healthcare is local, ultimately. And so you need these high-profile programs in order to help gain the awareness, stimulate the change. And what we're getting better at, fortunately, is capturing what's going on in these healthcare organizations and communities, what works, what doesn't, how can we do it better in the next community or the next organization.
Yes. Jen, your thoughts on that, Jen?
Sure. Well, by 2012, Beth Israel Deaconess has a goal of eliminating all causes of preventable harm. It isn't reduce at 20%, it's 0. So as of today, our current ventilator-associated pneumonia rate is 0.
Right.
Our current surgical site infection rate is 0. And our current catheter-related infection rate is 0. Now, this program basically suggests that we should be targeting 0 error rates, that we should be really getting to over the course of time, because it will take a lot of innovation to care that it is a high value, it's high quality, lower cost, and much safer. So Don Berwick, of course, a great leader from the IHI, has taken many of his philosophies now to CMS, and so I think his triple aim of more accessible, affordable care that's safer is what's going to drive the CMS policy for the next several years.
Oh, I think so, very much so.
What about the, and John, I'll start with you, what about the limitations of those types of programs? And I asked that, in my role, I work with the whole swath of providers, from the community hospitals to very sophisticated large hospitals. And sometimes it strikes me that different people have different levels of ability to react to programs like that. Different organizations, some have more than others. So are there limitations to those types of programs as you think about how they apply to the broad swath of healthcare?
Well, sure. So healthcare in the U.S. is extraordinarily heterogeneous. We have small community hospitals, we have tertiary academic health centers, we have solo practitioners, and we have 800 member group practices. Very challenging to say one size fits all. And especially for struggling organizations that are under-resourced, who may not have the dollars to put into, say, IT innovation, it may be challenging to achieve some of the process improvements that this kind of program will require. In fact, it may lead to more consolidation of organizations, so you get more homogeneity and more resources. So I think federal policy, as you said, has to set us on a direction and a path that ultimately there will be local variation as to how we traverse that path. And what you hope is that the learning that may start in some more well-resourced organizations then trickles down to the less resourced organizations.
I think if there's one thing I hear repeatedly, it's that organizations are tired of being told what needs to be done. They want to be helped with how to do it. But there's a balancing point, because when you bring these top-down types of programs, either from the federal system or accreditation organizations or state systems, if you start telling too specifically, then you get a reaction of, no, don't tell me what to do. So there's this fine balancing act, and that's where the benefits of some of these non-governmental initiatives actually help to create the change, because it's more neutral territory. We know what needs to be fixed. We have some solutions. We need more. We need to get that dispersed along the lines of what you were describing.
That's a great point. Thank you. So let's come back to meaningful use, and we touched on it a little bit. But as we think again about the different provider settings, how do we think meaningful use will impact safety over time?
Well, sure. So let's think about what meaningful use really is. So, three-stage program. 2011 is about getting the data in electronically. 2013 is more about sharing data, and 2015 applying intelligence, decision support, best practices, care plans. So the United States has really, unfortunately, lagged much of the world in implementing electronic health records. If we're going to improve medication safety, well, we better actually have medication lists, and we better have e-prescribing. If we are going to treat you appropriately, we better understand your problem list. If we are going to make sure we don't have errors of transcription, we better eliminate handwriting. And so what meaningful use does, and by having 15 core requirements, is it takes us through the electronic medication and problem and allergy and ordering, and then in a series of menu set items where you have 10 of which you pick 5, it tries to push the envelope a bit by saying we are going to coordinate care, and transfers of care are going to be electronic. We are going to have medication reconciliation. We're going to have public health surveillance. And I think all of these things have accelerated the progress on healthcare IT much faster than the market alone would have accelerated it. So it sets a foundation for patient safety so that as we get to the data exchange of 2013 and the decision support of 2015, we'll have the electronic data necessary to offer wise counsel in giving the right care to the right patient at the right time.
Although, that sounds great, but we know historically that healthcare is really a slow adopter type of industry when it comes to technologies. And we are probably somewhere around 8 years behind other industry already in terms of adoption of technology. And my own sense of this schedule, while it's important, it still just might get us up into a basic infrastructure. It's not going to take us into a step forward into the future as to where health IT needs to be in order to create true safety. And you know, I've done my own informal polling around with some of the IT gurus. I haven't hit you yet, but but I hear numbers of it's actually going to be 20 to 25 years before we really have a nice, well-functioning, pretty seamless HIT system. So the meaningful use gets us started and jump-starts us, but we got a long way to go yet.
Well, and so let me just suggest that, I don't know, in the 1980s, did you have a fax machine? You know, one of those early adopters of that new technology. Turns out it was almost useless because very few people had fax machines. Sure. So you had no one you could send a fax to. So what I would argue is we will end up with what I'll call Moore's Law. That is Moore's Law, which says the value of the network is the square of the number of participants. So here, what I think we're going to see is more and more people are going to get EHRs, which is going to demonstrate value, and suddenly there's going to be private investment, and suddenly you're going to have an acceleration. So if you didn't have that foundation, if you didn't have the fax machines, you would have never had the secondary investment, the recognition of value. I think it'll be faster than 20 to 25 years.
I hope so, and we've needed the feds to come in and give us this meaningful use initiative, you know, to get that foundation in place.
No question. What about similar vein in terms of health IT and information and data in the network, adverse event reporting and patient safety organizations? I'm curious, at Beth Israel Deaconess, what's been your approach to adverse event reporting and capturing data about safety specifically?
Sure. So a challenge with adverse event reporting is creating a vocabulary to describe the event. And so, alas, one of the challenges in medicine is, see, I call it high blood pressure, you call it hypertension. They're the same concept. We describe them differently. Well, if a patient falls, or a patient has a medication mistake, or a delay in treatment, how do we codify that? So what we've had to do internally is build an ontology, that is a structured vocabulary of describing the events, and then everyone in the organization in a singular database keeps a longitudinal record of every single event, so it's mineable and shareable.
Right. But that's an institution.
That's true.
And you know, you guys have been in the lead for some time, and interestingly, about 5 years ago, 6 years ago, there was a patient safety taxonomy developed. The Joint Commission did that. They put it through the National Quality Forum's endorsement process, and what was the uptake? Not much anything, really. Similarly, there has been a World Health Organization initiative to set up an international classification for patient safety. We've all heard of the ICD-9, ICD-10. Well, this would be international classification, or ICD, for patient safety. Getting that through the WHO bureaucracy has been tedious and slow, and you get into the difficulties immediately. Well, some of those terms may work in this country, but they won't work in that country, and so how do you get this? So we are still at that stage where organization by organization we're kind of struggling along, that everybody's got their own definitions, their taxonomies, et cetera. And we need to broaden that out so it's more on a federal level.
And this is where the federal government can actually accelerate the work, because standards are something that typically, they're actually not made, they're adopted, as you've pointed out. And so if we all have a problem to solve, and we all try to solve it locally, and then eventually we all agree, it would be great to interoperate. Then we'll all come together and the standard will be adopted. And the federal government can facilitate that.
I think, and my hope as it relates to the taxonomies of safety, is that PSOs can be the center point to bring the networks together and drive that common adoption of a common taxonomy. But then I love your comments on this. what strikes me about PSO adoption, I think there's been some PSOs have struggled to execute on the basics of being a PSO, but there's also this conflict between the federal statute, which creates PSOs, and this landscape of state statutes. In California, you have Rule 1157. In Florida, you have Amendment 7, and there's 48 other flavors, or maybe 23, but there's many other flavors that conflict, complement. Any thoughts on the potential for PSOs to overcome that network or that conflict between state-level legislation?
And this is a really interesting problem in many ways. So it turns out in Massachusetts, we've tended to think it's actually a good thing from a safety perspective to keep a record of all the narcotics that are administered to every patient. So that if you come into the emergency department saying, you know, I've got this back pain, I've never had it before, but 250 milligrams of Demerol, that'll cure it, and then I'm able to go into a database and find that you've gone to 40 other ERs in the last 2 weeks, I can actually improve your care, do the right thing, and achieve safety and hopefully a good outcome. In New Hampshire, it's illegal to keep a database of that nature. So one state says do it, the other state says you can't. And so ultimately what has to happen at a federal level is that we end up with policy that gives us a direction, and then the states can implement it differently, but we need a common direction.
Well, we tend to forget, though, that when the original Institute of Medicine reports to Err is Human and the Quality Chasm came out, within a lot of that interaction was the concept that there should be a voluntary federal reporting system and that there should be mandated state-based reporting systems. And here we are 10 years later, and we're only just starting to get there. The Patient Safety and Quality Act of 2005, which set up for the PSOs, was 2005. So here we are, 6 years later. We've been active with the PSO initiative for only about 2 to 3 years. And it still remains to be seen. While there has been efforts to unify the reporting structure, the common formats, if you will, the uptake and utilization of PSOs is still fairly light. On the state side, mandated state-based reporting, there's only 27 mandated state-based reporting systems, and they come with all flavors and varieties. And Massachusetts is one of the stronger ones, but it's all over the map in terms of what the expectations are, and many states are not willing to even go to doing mandated state-based reporting yet. So we've got a long ways to go in terms of getting a functional reporting system that can be utilized. The PSOs, hopefully, will stimulate some of that further.
Heck yes, thank you. And I'm optimistic that they will. So let's talk about the similar vein, the non-punitive environment that's sometimes necessary to improve safety, and the notion that it's often said that blame is the greatest enemy of safety. Starting with you, Peter, what are your thoughts on how we balance transparency with accountability, and at the same time manage the regulatory pressure? And you have a page I've seen that shows all of the reporting that an individual hospital must manage at any given time. So how do we manage all of that reporting with transparency and accountability, right, and do it gracefully?
Gracefully. Well, at least we're even talking about transparency nowadays. 5 years ago, we didn't even have that. We weren't talking about transparency. It's important to know that we like to have this concept now that if something bad's going on, let's be open about it. Let's even apologize for it. There's a number of cases out there in states that have adopted laws that say if a bad event occurs in an institution, if, John, you have a bad outcome, it's okay for you to go and say, I'm sorry, this is what happened, right, we're on it. And whatever you said doesn't get brought into the whole discoverable evidence piece. And that's a big and important step. I think, though, that we have a long way to go still in terms of this non-punitive environment. And again, coming back to this common era of patient safety in the early part of this decade, well, it was if you, John, did something, then by gosh, you're out of here. If it was really egregious enough, you go try and find another job somewhere else. And then we swung all the way around. Well, we should save John. He's a nice guy, really. And look at the system he's working in. He's got problems there. How anybody would fail there. And so we went that other direction. But now we've recognized that, it's going to take a while for the systems to get changed. It's going to take a while for everything to get smooth and protect the human beings who always are going to make some errors. And inevitably, we will make errors. Sometimes we do it without intent, sometimes it's intentional, sometimes it's bad circumstances. I'm sleep deprived, I've got my medications from New Hampshire and I'm working in Boston,
Exactly.
you know, those sorts of things. So we need to have individual accountability still come into place. So we're in a pendulum swing back. Look at the individuals, look at the systems, discover what really occurs and where's the balance of what was the cause of the error in the first place.
Please.
Yeah, no, I would certainly agree that creating a non-punitive culture, very, very important. So we wouldn't fire the nurse. We'd actually understand why the medication administration system was broken and facilitated the error. And it may be such things as, oh, there are two containers side by side. One has Levophed, the other has, you know, some very similarly packaged medication, and it's you know, a commonly used sorts of thing. Oh, grab the wrong one because they were right next to each other. So we would change what we do and how we deliver the care. But as some examples, to try to create the transparency, we put all of our errors on our public website. And so at www.bmc.org, you can actually see all of our infection rates, all the falls, all the mistakes we've made, wrong side surgeries. Anything we've done wrong is publicly viewable because we've said this is all about creating a learning healthcare system. So that's good. And then sometimes there are IT process changes. So example, the wrong side surgeries that do occur, you ask, why? And it's often exactly as you described, sleep deprived, I'm rushed. Well, what if Atul Gawande said, you know, there's a pilot checklist and we're all going to take a moment before the surgery, go through the pilot checklist, and then before the first scalpel blade is given, everyone agrees what we're going to do and how we're going to do it. We actually automated that process. So it's a computer-based pilot checklist that all members of the care team sign off on before the scalpel is opened. And these sorts of things have created a culture of continuous improvement that, you know, we're never going to be perfect, but we can be on a trajectory toward perfection.
By all means.
And what's been the reaction of your staff to that, automating the checklists?
Extraordinarily helpful because, well, anytime you make a change, of course, people are always dubious. You know, is this going to take more time? Is this, you know, Big Brother watching me? But when they discover that it actually protects them from creating harm, it's like provider order entry. You know, 10 years ago when you said you're going to enter all your orders by computer, some doctors said, but that takes away my autonomy. Medicine is art, not science. And it was the first time they were protected from giving a medication that would have harmed a patient. They said, I get it now.
Mm-hmm. And I think, you know, pretty much all clinicians, whether it's docs, nurses, pharmacists, et cetera, they are now very much aware that they want the best quality, the highest level of safety, and hopefully soon we'll get to the best efficiency of care for their patients. And now that there is test cases and research findings and a variety of organizational approaches that are becoming accepted as showing that it's safer for my patient, there's a better adoption that's coming along. They want that reassurance, and we're fortunately finally at a stage where we can offer that reassurance.
Heck yes. Oh, you mentioned the website, which I was unaware of. That's an interesting and I think a great idea, that level of transparency. Can you give us other specific examples of ways that you're using technology at Beth Israel Deaconess to improve safety?
Well, sure. So back in 2001, our CEO said, medication error is job one. Everybody focus on improving the medication administration workflow process. So since 2001, we haven't had a handwritten order for medications. But here's the problem. I write you for a perfect medication. I've checked it against your drug-drug interactions, your allergies. The nurse knows exactly what to give you. The nurse goes to the pill cabinet and pulls out the wrong pill. Or the nurse goes to the pill cabinet and gives it to the wrong Mr. Smith. So what we haven't yet done, and that's the current project, is to ensure with positive patient identification and barcoding of every single medication that at the point of administration, electronic medication administration records and bedside medication verification are done, so it's truly closing the loop. Mm-hmm. Another example of closing the loop. You have chest pain. He's a cardiologist. I refer you. You never go. Problem is we build IT systems that if something occurs, I can say whether it's right or wrong, but I have no IT systems to deal with things that don't occur. And so trying to build closing the loop on the referral, exception reporting, having a patient-centered medical home where you're given effectively a dashboard on each patient to understand where they are in the process. These are some things that are currently in process.
Well, that brings up the weak link in a lot of this stuff, though. And we've so far been talking primarily about providers and organizations and the systems and the processes, but patient compliance and patient errors themselves are oftentimes something we cannot control for. So one of the debating points oftentimes was, how is it that we bring patients into this whole level of discussion, and then how do we get them to engage even if they do come in? You know, we mentioned some of those resource websites. How many patients are actually going to go off to Hospital Compare or upcoming Physician Compare? Probably less than 10%. Most patients still like to stay local. They hear it from their aunt or their uncle or their brother or their sister. Dr. X is good, Hospital X is better. So they make personal choices. So how do we get the patients in, and how do we get them to comply? It's still like 50% on this compliance thing with patients.
Well, so my daughter turned 18 this month, and she is, of course, been born really the same year the internet was born. She is connected to social media and mobile devices. So when we say things like personal health records, and your data will be shared with you, and action plans will be shared with you, and care teams will be shared with you, and you interact with your doc electronically, her answer is, of course.
Yes.
As opposed to my mom, and she's okay with me saying this, but she doesn't do email. My father prints out the email, which she reads, handwrites a response, and then he types it back to me. She may not be the electronic steward of her own health care. So some of it is generational, and I definitely think the technology stack to engage patients in shared decision-making is really there.
And I wonder if it's generational. I also think it's probably there's an elegance required to get people to consume information at those sites and simplify it. And I think of the success of Apple in simplifying things, and how do we simplify information so people can consume it. Peter, I'd love to close. What else have you seen, broadly speaking, other successes in terms of technology being deployed? We heard a few great examples. Other things that you've seen around technology improving patient safety?
Well, I think, you know, the electronic health record uptake is going to continue to snowball and grow, and the momentum is clearly there now, especially with meaningful use into place. I think that the CPOE, or the computerized practitioner order entry for medication, is certainly a big piece of it. Where we need to go, though, still is the integrated medical record that gets you all the way from your home care to all the way when you're sick and needing to go off into other levels of care. Getting the patients engaged is just starting, as we've been saying. There's a variety of e-portals. When you look at the surveys, what is it, 2/3 to 3/4 of the population is out there using the internet to check on their health status. But when you look down the list, and we saw this slide a while back, the actual interaction on their health information is very poor. It's on the order of 2%, 3%. So, you know, I think while I'm not answering your question specifically, it's because we still have some lacking. Now, on the good side, you mentioned Apple, and we hate to sort of give vendor-specific responses, but a phenomenon that's being recognized now in the physician community is the uptake of the specific Apple products, the iPhones and the iPads. And the other competitors, the Droids and the RIM products, are not getting taken up to the same level. And so the application use is what's got everybody utilizing. And I think there's tremendous opportunity that we just are starting to tap into in terms of how to improve further the interaction of the providers, the patients, and the institutions together.
Thanks for that, Peter. Well, and so John, clearly I'm sure you have requests for Apple products, and this uptake, I think this adoption is difficult to ignore. What's been your strategy, or are you purchasing iPads for your staff, for example?
So as of this morning, there are 1,800 iPhones and 600 iPads on our network. Now, I have purchased 0 Apple devices for the clinicians. They're buying them themselves. They become a lifestyle device. So what do I do as a CIO? I provide the software in the background that an Android or Apple device can connect to, but I then leave the purchase of the device up to the clinicians themselves. So it has not been a capital burden.
Yes, terrific. Well, with that, I think we'll wrap. Thanks again very much for being here. I enjoyed it. I'm sure our audience did as well. And we'll now transition to the live question and answer, and we look forward to speaking with you.